The kidneys are the body's most stoic organs. Unlike the heart, which pounds when excited or frightened, or the lungs, which gasp when overworked, the kidneys suffer in silence. They possess a remarkable, almost dangerous resilience, where a human being can lose up to 90% of their kidney function before a single symptom becomes obvious enough to warrant a doctor's visit. By the time the alarm bells finally ring, often manifesting as fatigue, swollen ankles, or foamy urine, the damage is frequently irreversible. This phenomenon has earned chronic kidney disease the moniker of the silent killer, a title it holds with a grim statistical weight affecting more than 850 million people worldwide, which is more than diabetes or cancer combined. But the silence is not absolute. Deep within the molecular machinery of the renal system, there are whispers of decline, long before the shout of failure. The challenge for modern medicine has been decoding these whispers. For decades, we have relied on a blunt instrument known as serum creatinine to measure a delicate process. We have used static thresholds for a dynamic, aging population, often diagnosing the elderly with disease they do not have, while missing early warning signs in the young. We are now entering a new era of renal precision medicine. It is an era defined by age-indexed markers, where normal is no longer a single number on a lab sheet, but a fluid spectrum adjusted for the decade of life you are in. It is an era where we look beyond simple filtration to the health of the tubules, the level of fibrosis, and the biological age of the organ itself. To understand why we need these new markers, we must first appreciate the natural trajectory of the aging kidney. The concept of renal senescence is distinct from disease, though the line is often blurred. The kidneys are vascular organs, filtering the entire blood volume of the body roughly 60 times a day. As we age, this engine naturally downsizes. Starting in our 30s and accelerating after age 50, the kidney loses mass, primarily in the cortex, which is the outer layer where filtration happens. A healthy 30-year-old kidney might weigh 250 grams, but by age 80, it may shrink to 180 grams. Furthermore, we are born with roughly 1 million nephrons or filtering units per kidney. This is our renal reserve. Unlike the liver, which can regenerate, the kidney cannot grow new nephrons. We lose them steadily due to oxidative stress and hemodynamic wear and tear. By age 70, a healthy adult may have lost 30 to 50% of their functioning glomeruli. Alongside this mass loss is a hemodynamic shift. Blood flow to the kidney decreases by about 10% per decade after age 40. This is partly due to the narrowing of the renal arteries and the stiffening of the smaller arterioles, a process called glomerulosclerosis. Interestingly, the filtration rate drops more slowly than the blood flow because the remaining healthy nephrons work harder, a phenomenon called hyperfiltration. While this maintains function in the short term, it can accelerate burnout in the remaining nephrons, much like an engine redlining to maintain speed. Perhaps the most critical silent change occurs in the interstitium, the scaffolding that holds the nephrons together. With age, this tissue becomes fibrotic or scarred. This low-grade fibrosis acts like a choker, stiffening the organ and impairing the delicate exchange of electrolytes. This is often why older adults are more prone to dehydration or electrolyte imbalances during heat waves, even if their filtration rates look normal. This leads us to the flaw of the one-size-fits-all threshold. For years, the medical community used a fixed cutoff to diagnose chronic kidney disease, specifically an estimated glomerular filtration rate, or eGFR, of less than 60. If your eGFR was 59, you had disease. If it was 61, you were normal. This binary approach is increasingly viewed as flawed. A natural decline in eGFR is part of healthy aging. A rate of 55 might be alarmingly low for a 30-year-old, indicating significant pathology. However, for an 80-year-old, a rate of 55 might be perfectly adequate stable function, reflecting physiologic senescence rather than kidney disease. The consequence is that millions of elderly patients have been labeled with stage 3 disease, leading to anxiety and unnecessary referrals, when in reality, their kidneys will outlast them. Conversely, a rate of 80 is considered normal by the fixed threshold. But for a 25-year-old who should have a rate of 120, a reading of 80 represents a massive 33% loss of function. The consequence here is that young people with early, aggressive kidney disease are told they are fine until they crash into stage 4. Leading nephrologists and recent guidelines are moving toward age-specific definitions. For those under 40, normal should be above 75 to 90. For those between 40 and 65, the standard threshold remains useful. But for those over 65, a threshold of less than 45 may be a more accurate definition of disease. If the thresholds are changing, the tools must change too. Serum creatinine, the gold standard for 50 years, is notoriously flawed because it is a waste product of muscle breakdown. Therefore, a frail elderly woman with low muscle mass might have normal creatinine despite having very poor kidney function. Conversely, a bodybuilder might have high creatinine with healthy kidneys. To detect the silent alarm, we need next-generation biomarkers. The first is cystatin C, a protein produced by all nucleated cells in the body at a constant rate. Unlike creatinine, it is not affected by muscle mass, diet, or inflammation. It is the superior marker for the elderly and early decliners. Guidelines now recommend that if an older adult has a creatinine-based eGFR between 45 and 59, it should be confirmed with a cystatin C test. In up to 40% of cases, this reveals the kidney function is actually higher, removing the diagnosis. The second tool is albuminuria. While filtration rate measures how much blood is filtered, albuminuria measures how well the filter is working. The presence of albumin protein in the urine is the earliest sign of endothelial damage, often appearing years before filtration begins to drop. The third set of markers includes KIM-1 and NGAL. These are markers of tubular injury. While creatinine tells you the kidney has failed, these molecules tell you the kidney is under attack. Currently used in research for acute injury, they may soon be used in routine checkups to predict progression. Finally, there is suPAR, an immune-derived molecule that circulates in the blood and can damage kidney podocytes. High levels have been linked to future disease development even in people with currently normal function, acting as a long-range forecast. Kidney health is a lifelong project, and the silent alarm sounds different at every stage of life. In your 20s and 30s, you are in the baseline era. Peak renal mass and function should be present. The silent risks here are autoimmune diseases and genetic conditions. Uncontrolled lifestyle factors like obesity and high sugar intake begin to lay the groundwork for hyperfiltration injury. The checklist for this decade involves establishing a baseline blood pressure, as hypertension in your 20s is a major red flag. A simple urinalysis can check for protein or blood, often the only sign of IgA nephropathy. You must also be wary of NSAID abuse, such as ibuprofen, which is common in active young adults. Moving into the 40s and 50s, we hit the metabolic turning point. Renal menopause begins as structural involution starts, and filtration declines by about 1 milliliter per minute per year. This is the onset of type 2 diabetes and essential hypertension, the two biggest killers of kidneys. The metabolic syndrome strikes here. The checklist now requires annual eGFR and albumin to creatinine ratio tests. You must also watch for nocturia, or waking up to urinate at night. Waking up once is often normal, but 2 or 3 times warrants a check. This is also the decade to reduce sodium intake to lower glomerular pressure. In the 60s and 70s, we enter the preservation phase. There is a significant loss of renal reserve. The kidney becomes less able to concentrate urine and conserve sodium. The silent risk is polypharmacy. Drug-induced toxicity from antibiotics or proton pump inhibitors is common. Vascular disease may also reduce blood flow. The checklist prioritizes cystatin C over creatinine due to muscle loss. You should conduct a medication review with a pharmacist to see if any drugs need dose adjustments based on kidney clearance. By the 80s and beyond, we are in senescence management. A normal eGFR may be 45 to 50. The goal is stability, not restoration. The silent risk is acute kidney injury from dehydration or infection. A minor illness can tip a fragile kidney into failure. The focus here is on fluid management and conservative care, prioritizing symptoms over numbers. We can no longer treat the kidney in isolation. It is the nexus of a triad of aging that determines longevity, involving the brain and the muscles. Cognitive decline and renal decline share a startling correlation through the kidney-brain axis. Both organs are low-resistance vascular beds, receiving high volumes of blood flow, and are susceptible to pulsatile damage from stiff arteries. Furthermore, uremic toxins that healthy kidneys filter out can cross the blood-brain barrier, causing real cognitive issues known as renal fog. Protecting the kidney is protecting the brain. Treating albuminuria has been shown to slow the progression of white matter lesions. Similarly, the kidney muscle axis is vital. Sarcopenia, or muscle wasting, is not just a side effect of kidney disease, it is a driver of it. Muscles act as a reservoir for amino acids and help regulate insulin sensitivity. As muscle mass fades, insulin resistance rises, damaging the kidney. Conversely, failing kidneys produce inflammatory cytokines that actively dissolve muscle. Therefore, resistance training is a renal prescription. Beyond standard care like ACE inhibitors and statins, the field of longevity science is producing exciting new interventions, targeting the biology of aging itself. First, we have senolytics, which clear zombie cells. Senescent cells are old cells that stop dividing but refuse to die, accumulating in aging kidneys and secreting toxic signals that damage healthy neighbors. Drugs like dasatinib plus quercetin and fisetin have shown the ability to selectively kill these cells, with early human trials investigating their ability to reduce fibrosis and rejuvenate tissue. Second, there is Klotho, the anti-aging hormone produced primarily by the kidney. Klotho suppresses oxidative stress and prevents fibrosis. Levels of Klotho drop very early in kidney disease, often before creatinine rises, making it the earliest silent alarm. Klotho replacement therapy is a hot area of research. Third, we look to NAD+ precursors. The kidney is the second most energy-hungry organ after the heart. Its fuel is ATP produced by mitochondria using NAD+. Levels drop sharply with age, creating an energy crisis. Supplementing with precursors like nicotinamide riboside has shown promise in animal models to restore mitochondrial function. Lifestyle also acts as medicine, but the renal diet must be age-indexed. For young and middle-aged adults, high protein intake can induce hyperfiltration, so moderation preserves reserve. However, for the elderly, sarcopenia is the greater enemy, so they often need more protein to maintain muscle, preferably from plant-based sources which induce less hyperfiltration and acid load. Additionally, aging kidneys struggle to excrete acid, leading to metabolic acidosis that eats away at bone and muscle. An alkaline diet rich in fruits and vegetables neutralizes this. Intermittent fasting and caloric restriction are also powerful, as fasting triggers autophagy, the cell's self-cleaning mode, allowing the kidney to clear out damaged mitochondria. For those where the alarm rang too late, the future holds mechanical and biological solutions. The Kidney Project is developing an implantable bioartificial kidney the size of a coffee cup. It combines a silicone nanofilter to remove toxins with a bioreactor of living kidney tubule cells to balance electrolytes. It runs on blood pressure without batteries and requires no immunosuppression. Simultaneously, xenotransplantation is becoming a reality. Recent breakthroughs in CRISPR gene editing have allowed scientists to humanize pig kidneys, removing sugars that cause rejection, and inserting human genes to regulate inflammation. Clinical trials of pig-to-human kidney transplants have begun, representing the potential end of the transplant waiting list. The renal silent alarm is not a sound. It is a summons to attention. It is a call to shift from reactive medicine, treating failure, to proactive maintenance, preserving reserve. Kidney health is not just about avoiding dialysis. It is about preserving the body's chemical equilibrium, protecting the brain from toxicity, and maintaining the structural integrity of our muscles and bones. By adopting age-indexed markers, leveraging the new toolkit of biomarkers, and embracing longevity interventions, we can turn the silent decline into a loud and vibrant longevity. The kidneys may be silent, but the data is speaking. It is time we listened.